Hello, everyone, and welcome to this edition of the Neurology Video Journal Club. My name is Hans Katzberg. I'm a neurologist and neuromuscular specialist at the University of Toronto at the Krembil Brain Institute and University Health Network, the Prosserman Center for Neuromuscular Diseases. And I'm joined here with Dr. Carolina Barnett-Tapia, who's also at the University of Toronto and at the Prosserman Center for Neuromuscular Diseases. Welcome, Carolina, and very happy to have you join me today for this discussion.
Thanks, Hans, for inviting me to discuss yet another great interventional paper on myasthenia gravis.
So, Dr. Barnett Tapia and I are colleagues, and we work at the Neuromuscular Center here. And both of us are very interested in all neuromuscular diseases, but in particular immune neuromuscular diseases. We've spent, I think, most of our careers also focused on myasthenia gravis, which is the topic today. And it's a very exciting time for myasthenia gravis because there's a number of new therapies that we have available that are already being used, and many more that are also coming up. And that is the topic of today. And Carolina, you've also been involved in one of these, so welcome back to join us for another discussion of a paper.
Yes, no, it's exciting, and we hope that this discussion brings some thoughts to everyone who's watching, and hopefully, incentivize some further research and clinical practice.
Great. So today, the article is Safety and Efficacy of Nipocalimab in Patients with Generalized Myasthenia Gravis. These are results from the randomized phase 2 Vivacity-MG study. And I will start with a summary of this article, and then we'll go into a bit of a discussion. I think the most important thing to start with about this study is that it is a phase 2 study. So there's a number of other similar class medicines that are already in phase 3 with results, but it's important that this is a phase 2 study. So a lot of our discussion will be centered around the fact that it is a phase 2 study. It is a human monoclonal Fc receptor inhibitor. And this class of drugs, similar to this product, is designed to bind and saturate block IgG binding site of FcRn with high affinity, inhibits recycling, and lowers IgG, including the pathogenic autoantibodies. So that is the mechanism by which these drugs work. And this product that has been engineered to remove immune effector functions, including Fc gamma receptor and complement binding. So it really has some good mechanistic uh, pathogenic targets that could have potential to help in MG. And there's been other products which we'll discuss that have similar mechanisms. So this is another option for us to use in MG. So as I mentioned, it's a phase 2 study. It is randomized, placebo controlled. There was 14 placebo patients and 54 treated patients. And the reason for this discrepancy is that this was also a dose finding study. So that's why you have more patients in the treated group that were um, randomized to different doses of the nipocalimab group. So this included a single 60 milligram per kilogram dose, a 60 milligram per kilogram every 2 week dose, 5 milligram per kilogram every 4 week, and 30 milligram per kilogram every 4 week dose. So this is the four groups that were treated compared to placebo. And the population really did reflect a population that received standard of care but still had inadequate responses. So this was not truly a refractory population, but these were patients with inadequate response to standard of care and really reflected kind of our challenging MG populations, people that were already on pyridostigmine, off many of them, in fact, more than half were on steroids or steroid-sparing agents, still didn't have an adequate response with an MG-ADL, the activities of daily living score greater than 4. And the primary outcomes here, as with any phase 2 study, is safety. And then there was an efficacy aim that the study was powered to. This was dropped in the MG-ADL compared to the baseline scores. And secondary outcomes were the IgG levels and other pharmacokinetics, anti-drug antibodies, and a number of other secondary efficacy parameters. So maybe I'll pause there and just, Carolina, any thoughts on just the design of the study, how it compares to some of the other MG studies so far before we go into the results?
Yeah, so it's very similar in the way that a phase two goes is safety and finding the dose. So other studies in the same class of medications have also compared different groups and different doses, and to find the optimal schedule for going further on that phase three. One thing that I found interesting is that the population is slightly milder than some other studies on MG. So using the MG-ADL, for those of you who are not as familiar with the myasthenia gravis research, is one of the most common outcome measures, and it's a patient-reported outcome. Most studies are using a minimum of six. One has used five as the smallest number for enrolling patients. So this study enrolled patients even down to four. So it's including some patients with slightly milder disease. So that's something to take into consideration for generalizability of the findings. But other than that, the rest of the design is very much in keeping with other similar phase 2 studies.
First slide we'll have up is actually the consort diagram, which shows all the patients that I mentioned and their allotment into the different randomized strata, as well as the placebo, and then some of their outcomes. And then I'll just move into just kind of highlighting some of the main results. I think one of the main results is that of a dose-dependent reduction in the MG-ADL score from baseline over placebo. So pairwise mean ADL comparison changes didn't significantly change compared to placebo, but it's important to note that the study was not powered for that. It was powered only for the dose effects, really trying to find that optimal dose that can then be taken to a phase 3 study. And also importantly, percentage of patients that achieved a durable response at day 57 was higher in all the treatment groups and statistically significant in the 60 milligram every 2-week dose. The nipocalimab was generally well tolerated. And I'll show you that in a second. But in slide 2, we also have some of these change from baselines in the MG-ADL score. So you can see there in comparison to the placebo line, which is in red in each of the slides, you can see the different doses, and you can see essentially the depth of the MG-ADL drop, which is not as robust in the lowest dose, 5 milligrams per kilogram every 4 weeks. And you can see there that at the 60 milligram per kilogram every 2-week mark, that's when you see the biggest effect. And you can also see the effect of the single dose, which really allows the patient to improve in the MG-ADL. But in that, as I'll tell you, the depth of the response was achieved up to day 29. So that tells us a little bit about how long the drug works after you give a single dose. So as mentioned, the next main points to look at are the safety and tolerability. So generally, the drug was very well tolerated. TEAEs, treatment emergent adverse events, were similar in both groups, including infections. So that's obviously something we pay close attention to in the FC and other immune targets for MG. All these treatment emergent adverse events in the treatment group were mild or moderate. The most of them were headache, diarrhea, and nasopharyngitis. So this again is similar to other classes of medications with the FC receptors. And the anti-drug antibodies, which were also measured, these did occur, but they were relatively transient. So they kind of um, went away over time, much less to a lesser degree, and they did not affect the clinical efficacy parameters. And then finally, there was mild dose-dependent decrease from baseline in the mean albumin, and there were some observations of dose-dependent cholesterol and LDL increases, but these were not felt to be clinically significant. So that's a summary of the paper. Carolina, I'm curious to get your thoughts just on those results that I've mentioned and what you think the paper adds.
Yeah, so it's first of all, is the principle that medication is doing what it's supposed to do, which is reducing the levels of IgG, and that goes with reduction in the myasthenia gravis score. So I think this is what we expected to see because we already have approved medications in the same class that basically work in the same way. They're just designed differently to do it. So it's not a surprise, but we always want to see this before going ahead on a phase 3. The other thing that which is important with a single dose, and this is also a class effect, is that the response to these medications is transitory. So uh, because you're not changing the production of antibodies, what we're doing is taking them away from the circulation, right? So if you do one dose, you have a transitory good response, but if we stop it, then the antibodies will come up. So This points to the clinicians out there that if we decide to put a patient on one of these medications that are approved, or this one, if it goes forward and it gets approved later, it's something that has to be done periodically, and each will have its own dosing schedule. For this particular medication, every 2 weeks seem to be the better alternative. So unless you're also treating patients with something else further upstream, reducing antibody production, this would be something that has to be done in a permanent basis. So that's something to keep an eye. And it's not just for this medication, it's a class effect. In terms of the side effects, I think overall the profile was very good. There were side effects, but most of them were mild. Um, we looked at the albumin because it has the potential to be clinically relevant, but it was not clinically relevant. So the change was very mild, but I think that's something to keep an eye on for the phase three. And I think for all of these drugs that are so very new, when we go to having more real world evidence and, like even phase four real world data, we'll know whether there are any cases where this change is more clinically relevant. But so far, it seems to be a mild, mostly lab effect and not a clinically meaningful effect.
In regards to kind of as you mentioned the mechanism of action, so we do know the IgG levels drop, and in fact the other point that was made in the paper is that all the subtypes of IgG drop. So IgG 1 to 4, I think that's important. Most of the patients in this study were acetylcholine receptor antibody positive. Only 4 patients were MuSK, so really too early to draw any conclusions about other antibodies in MG or seronegative patients. But there's another slide we're going to have up here, figure 4 from the paper, that just does show you the drop in the base from the baseline IgG in all these doses compared to placebo. And again, you can see that in the 60 milligram every 2-week dose, that's when you get the most robust drop. And I suspect this is the group that is going to be, and in fact has been chosen for the phase 3 study. So we'll see more about that. But really, this was a good effort at the dose finding and a good correlate between the drop in IgG and also the clinical responses that you saw. So that lends a lot of credence to the fact that it's a good marker of efficacy, the IgG drop with the clinical.
Yeah, and I think what you're saying about the antibodies is that from a biological plausibility perspective, this should work in any type of autoimmune myasthenia. So we know in other of the approved drugs, one of them has been approved for mask myasthenia because they had enough power in their phase three studies to show a clinically meaningful change in mask. But from a biological perspective, we would expect those patients to benefit as well, right? As opposed to say complement inhibitors, where we know it doesn't make any sense to use in mask myasthenia. So this open ups for patients with mask where there are fewer studies and potentially for certain negatives. I know it's not the focus of this, but for those of you who may not be as familiar with myasthenia gravis research, most of the studies have focused on acetylcholine receptor positive, not more mask, but their negative population is a complex group that often is left outside of studies, and some of this class of medications have been studying are having studies now on zero negative patients, so it's something very exciting to look for.
So in regards to the administration, so it looks from the IgG levels, the efficacy, that this 60 milligrams every 2-week dose is the adequate dose. This is, as I mentioned, what will be tried in the phase 3. So we'll see the final results. But if that ends up being the recommended, what's your thoughts on that administration schedule? We have now Rosimab and the Efgartigimod, which have different dosing schedules. How do you see that, Carolina?
I think that is great because people have different preferences and different life circumstances. So this is an intravenous administration. There's some rosaliноxizumab is subcutaneous, efgartigimod, the myasthenia formulation for the studies was IV, although I know there's a subQ formulation with another indication. But I do a lot of research in patient outcomes and patient preferences, and looking at different studies. There are preference for different things. So there are people who may want to have the least amount of needles and will choose whatever gives them the least amount of times they have to have an infusion. So for some people, having this once every 2 weeks might be really good. Some people may like the schedule where they go 4 weeks on a row and they have some time off, and they might find that more better aligned with them. But I know some patients will not want to be off, will prefer the routine and knowing that there's little chance for them to drop or find that optimum dosing. Some people will like to self-inject at home, and some people will not want to self-inject. Or some people who are quite reluctant to do that. So I think this will add options for patients, which would be great. In terms of efficacy, we can compare them head to head. And again, this is a phase 2. I wouldn't expect them to be different in terms of efficacy. I think this will add options for side effects, for tolerance, and for convenience.
And thank you for highlighting that. In case I didn't make that clear earlier, this is an intravenous administration for nipocalimab. So, in regards to some limitations, of course, we have to always comment on the limitations. Of course, I think a lot of the intrinsic limitations are that it is a phase 2, so it's relatively small. Also, a short duration study. The main outcome was at 57 days, so about 8 weeks. And then, of course, the other challenge with the study, which was inevitable, is that this was happening at the same time as the pandemic. So, Carolina, what were your thoughts on that? Obviously, little that could have been done about that, a very difficult time. But how did that impact, for example, some of the outcomes collected?
Yeah, so they were recruiting right in the first wave in late 2019 and early 2020. So the QMGS, which is an outcome measure that's important, that has to be done by an examiner and request the patient to be there because there's spirometer and dynamometer. So those could not be done for a number of patients. So there's missing data more than you would like for a randomized control study. You also see that there were a number of patients who drew from the study because they didn't want to go and have a new intervention during a pandemic of a novel agent. So, um, you know, it is what it is. I think regardless, the data are going in the right direction. And I think now, I think we're moved to where now we are much better at doing some virtual assessments. And I think in the future, we're better prepared, I guess, if we need to pivot for studies. But, I guess inevitable in that way. I think the other thing that it's always interesting to me is there's always such a strong placebo response in the placebo group in the patients with myasthenia. So again, this is a small study, it's a phase 2. But if you look at the end of the study, the placebo group, the change in the ADL was close to 2 points, and again, very small number, but it's close to a minimum, what usually we consider a minimal important difference. So, and that's not just this study. Any of the RCTs and myasthenia are showing that the group in the placebo, there's a number of people who have a clinically meaningful response, and part of that could be the trial. But remember that a lot of these patients are taking medications, immunosuppressants that have a long time before they kick in. And I've always wondered that sometimes what we're seeing is a thiopurine kicking in after, say, a year. And oftentimes in studies, we request a small, like 6 months of stability of a new drug. So, it's something to keep our eye on for the phase 3 study.
And I think that's why it's key to have our phase 3 studies. And I think, fortunately, they had less of those challenges in their phase 3 study, which is now complete and will be reported soon outside of the pandemic window. So those QMGs were collected, and of course, larger number of patients, more broad population. So I think that will be very helpful to know, to confirm some of these effects, and have us glean some more insights. So in terms of implication for clinicians, what does this mean? Again, I think we have to wait until we have the higher level data with the phase 3 study, but it is an exciting potential addition to our arsenal of potential MG treatments. We have complement inhibitors, we have other immune suppressants that we've used traditionally, and then of course now we have multiple of the FC receptor inhibitors with the different administration profiles that give us different tools that we can use for MG. So I think that's the main implication of this potential help. It's also very reassuring that the safety profile is equivalent, very favorable compared to all the other FC receptor inhibitors. So again, another potentially safe option for us to use. Carolina, I was wondering if you could comment on the albumin and lipid changes that you heard. Of course, it was highlighted that these were not clinically significant. The targets did not raise them past into a concerning risk profile for cardiovascular disease, but these LDL and other cholesterol increases did occur. What are the implications kind of for clinicians as they look at that phase 3 study or potentially see this rolled out?
Yeah, I think we need to see the first three data and see how much of this remains. If it's still very minimal and really more a statistical change and not a meaningful, then I would that would be quite a relief, and that's what I'm hoping to see. If it was not the case, say if we see that the albumin drops more, then we would have to look things for edema, see if it's clinically meaningful. I believe for the other approved F3 receptors, not been a big issue. So hopefully this is the case. I was just on general neurology call recently, so I was mindful of calculating adjusted phenytoin levels based on albumin. So think about besides edema, whether if it really drops significantly, whether that has implications for other interactions with other medications. But this is very theoretical, and so far I would say the change is something to keep an eye on, but it looks non-significant so far, and I'm hoping that's the case. For the cholesterol, again, it didn't look too worrisome, and the LDL levels increased, but also the HDL, so the ratio was not as concerning. So perhaps I'm being optimistic. I'm hoping that this will be the case, and that hopefully we don't have to monitor for those, and it's just one of those things that we know happens, but is not clinically relevant.
Yeah, I agree, and I think it's important to note, as the paper highlighted, there was no grade 3 safety risk in regards to hypoalbuminemia. And as you said, the ratios of the cholesterol still were relatively minimally impacted. Of course, as we roll this out in real world data and real world patients, it's important to keep patients at higher risk profiles in mind. So we will pay attention to all the data that comes out to make sure it's a safe option for patients. So I think what comes next, I think certainly we've made many references to phase 3 data. That is the next step. We will see that very shortly over the next few months, results from that. And then as with all the drugs, we need to see again the longer term. This is a relatively short study. We want to see the long-term sustainable effects of this, similar to any other drugs, and also the real-world scenario. This is a very select patient population. Our patients are very complex with MG. And fortunately, in this study, it did try to mimic that with patients coming in already on existing standard of care. And we'll continue to see that and kind of multiple treatment strategies for each patient and how this fits into that. How about from the research perspective, Carolina, anything that you're excited about this or any other therapies?
Oh, it's impossible not to be excited with myasthenia gravis field now with all the medications coming. I think from research, big questions that I don't have answers. What about other groups? As you said, we don't have long-term data for these drugs. We have lots of young women who may have a pregnancy, so we don't have data, and potentially the class of FcRn blockers may be contraindicated because the FcRn receptor mediates the passive transfer of antibodies from mother to child. Although I believe this drug nipocalimab have been studied in women with risk of hemolytic disease of the neonate and has been okay, but that's a different population than myasthenia. So things that we don't know from research too. We are often asked, if you have someone who's not responding to standard of care, what do you do first? Would you go to a neonatal receptor blocker or a complement inhibitor? And we don't have any biomarkers to say who's going to respond to what. That would be really neat if we did, that we could kind of personalize a little bit the treatment as to what we think would be better. So that's a lot of research happening in those areas. And there's lots of very cool research going further upstream, trying to really stop the production of antibodies. And we're seeing cell therapy studies coming out from myasthenia. So, really, a very, very exciting time for the field.
Great, thank you. And also, I'm just reminded about other populations. You mentioned pregnancy, also children and adolescents. So I think there's a lot of effort and emphasis being placed on the fact that all these studies are in adults. So we really need some more evaluation for new options in that patient group. And also, over the time that we've had all these new studies, there's been really interesting discussion about outcomes and measures. For example, minimal symptom expression and kind of different things that we aim for, reduction of steroids and other immune suppressants. And can we do that in these patients over time? We've seen that a little bit in the open label extensions of the other study, and hopefully we will see that with this drug as well.
Yeah, absolutely.
Great. So with that, we will close our session, and hopefully you've gleaned a few of our insights from this paper. You can reference this and definitely look out for the additional results that will come out from the phase 3 study and other follow-up papers from these really major effort in generalized myasthenia. And with that, I'd like to thank Dr. Barnett-Tapia for joining me, and thank everyone for their attention and joining us today.
Yeah, thanks for having me. And yes, I think our emails are in the webpage if there's any comments that you want to add to our discussion today.
Thanks very much.